the top of the hour here. I really appreciate your time joining us for this part of our peer-to-peer financial performance webinar series. Today we have our guest Michael Hubble from the advisory board company. He's going to be doing a presentation called Competing on Patient Engagement. And just before we get started and introduce Michael, I'd like to cover just a few things. We will have the PowerPoint available for download at the end. We can also email it to you after the presentation if you'd like. We do have an online chat window at the bottom there. Please feel free to type technical questions into the Q&A box. If you have questions about the content of the webinar, feel free to type them in. However, we may wait until the end of the presentation to address those. And if we don't have enough time, we can respond via email. Throughout the presentation, we do have 2 poll questions that will be asked for your participation related to some industry topics that Michael is going to cover. And then at the very end, after the presentation, we also have a quick survey. We'd appreciate your feedback, and that's also when you can download the content for the webinar series. So with that being said, just one quick reminder that if you wouldn't mind throughout the presentation, please remember to mute your telephone or your microphone if you're listening through a computer, and we really appreciate that. I am going to gladly introduce Michael Hubble now to take over. Michael, please.
I'll start with a quick discussion of the emerging focus of health system competition, which is patient outcomes. Only health systems that engage patients at all levels will be able to achieve consistent, high-value outcomes and really attract new patient populations. I'll spend more time in section 2 there, our playbook for patient management. I won't go through every imperative there. I've selected a few that I think are most important for this conversation. In section 3, just a couple of pages to wrap us up, looking at the transition path to this new value-driven marketplace we've been talking about for the past couple of years. So we're migrating from the traditional fee-for-service marketplace where we're paid for individual services to a marketplace where we're instead paid for extended episodes of care. Things like value-based purchasing, readmission penalties, they make us accountable for the cost and quality of patient care beyond the 4 walls of the hospital. And certainly we are gradually moving from managing episodes to specific conditions to actually, in the long term, populations of patients. So medical home incentives, shared savings, other accountable care contracts are making us more accountable for the total cost and quality of care for a population. And that shift requires us to adopt some new success metrics and some performance levers. You see some of those on the page here. Population managers must merge the destination inpatient workshop with a more robust care management infrastructure if they want to get patient engagement. And maybe a simpler way to look at it, if you think about that shift, is on this page, shifting from competing on market leverage, where bigger meant better, to where a lot of folks are now, which is competing on referral dominance. How do we make sure that we've got the control over the more lucrative tertiary care through referral patterns, to how do we actually compete more on patient outcomes? That's the shift we're looking for. And if you think about that shift to competing on patient outcomes, there are 3 factors that influence health system success there. First is an integrated delivery system, one that can seamlessly move patients across different sites of care. Second, of course, is collaboration with physicians around shared cost and quality objectives. That might be employee physician groups, that might be clinical integrated networks, pretty wide variety there. And for today's conversation, patient engagement across different episodes of care and ongoing management. What we've found is that today's health system often falls short on all 3 of these. And as it's grayed there on the right, we're going to focus today on this question of patient engagement. One of the first ideas that I want to get across here is that patient engagement is not just a care pathway problem. So even when the health system offers patients this seamless experience, the patient themselves can still be disconnected, unprepared to take on the necessary self-management outside the walls of the hospital or practice. One of the greatest challenges facing population managers today is that gap between the system and the patients. You see a couple data points here. On the left, the 2 bars on that bar chart. We'll look at the second bar first. So perhaps not surprising that about 57% of patients say they knew their diagnosis when they left the doctor's office. a little bit better than half. That's depressing, but perhaps not that surprising. I found the left-hand bar a little more surprising, which is 77% of physicians believe that the patient knew the diagnosis when they left, meaning 23% of physicians knew as that patient left, they really didn't know what to do. Now, I don't mean to pin this all on physicians and say, therefore, it's their fault. There's a lot of factors that influence whether the patient knows that, but that is a depressingly low rate of physicians and patients saying, I knew what to do once I left the doctor's office. In fact, the real stark number, I think, is on the right-hand side of the page. Only 18% of patients could actually correctly identify the physician who'd been in charge of their care. Maybe more casually, I like to quote at the bottom of the page, for the patient, the health system is like being lost in a foreign country, not speaking the language. And if you think about the three pillars on the previous page, the coordinated system, the integrated physicians, the engaged patients, we think patient engagement stands out because an activated patient, they'll at least try to self-manage through even a broken health system. But a perfect system will fail if it doesn't have this patient partnership. And unfortunately, the reality here is that patients are easily disengaged, and I think it's fair to say, system from the patient's perspective. Because what happens is, as symptoms arise, patients eventually seek care. Many will take a wait-and-see approach, hoping symptoms will go away, but they'll eventually get into the system. And once they are in the system, patients are looking for the fastest route back to normal. In the interest of getting back to their regular day-to-day routines, they will skip steps in follow-up or in ongoing management. So most of our time in the health system is in the 12 o'clock to 4 o'clock section of this graphic, where the patient is actually seeking treatment at the site of care. However, most of their time is spent in 4 to 12. But as you move clockwise here, you get lower and lower levels of patient engagement. You see on the right there, 76% of patients leaving the hospital or the office confused about what to do next. 50% say, I have trouble using health information. This is where we see unnecessary costs and care variability happening. And as you think about what's happening in payment solutions here, most innovations in payment, they're happening in that 4 to 12 o'clock section. They're happening when the patient is outside the system. You see here at minimum, Medicare is requiring every provider reevaluate patient engagement and episodes of care if they want to avoid readmission penalties. Pioneer ACO, Medicare Shared Savings, they're bringing even greater incentives for activating patients and ongoing management. You see Medicaid following suit, new incentives for care delivery redesign. And every major commercial insurer is exploring some kind of accountable care contracting on the right there. So as we see the payers pushing for more population management incentives, all the key stakeholders in finance and delivery, everyone's lining up to lock in patients here. What we're trying to show on this page is some stakeholders are better positioned than others to do that. So you see health systems clear advantage in managing episodes of care. However, may not yet have invested in the primary care resources to do population management. Or one column over to the right, large physician-only groups. They're evaluating their opportunity for the role of population manager. As they do that, in many cases, locking the hospital out. Payers and employers exploring new partnerships for their own cost and quality goals. So the question that's being asked here is, who can best manage our populations? The providers that can offer a higher value product, they get preferential access to patients. They disrupt the existing provider-patient relationships. We're also seeing the disruptive innovators with an opportunity in population management, but they'll take a very different approach from the rest of the market. We're seeing innovators targeting retail channels, individual patients focusing on health and wellness. So with all that in mind, what does competing on patient engagement really look like? Well, first, it is elevating individual patient engagement in a discrete episode of care. This is like activating patients early in an episode or customizing discharge plans. Next is, can we drive engagement from groups of patients in ongoing care management? Can we prioritize support for high-risk patients? Can we leverage data to better identify changes in health status? And then finally, at least for some, transforming community health through engagement. Another way to think about the three phases here is in episodes of care, that's when we're enrolling patients in the system. In ongoing management in the middle, that's where we're retaining patients. And then in the final section, we're growing the population that we serve, adding new patients for management. We're extending the reach of the enterprise. So as we look at the three phases of value creation here, there are 11 corresponding best practices or imperatives for health systems that want to compete on patient engagement. I want to acknowledge one thing up front. There are very few organizations that have truly figured out patient engagement. So today, I'll talk about experiments, early pilots, projects, innovation that we're seeing organizations use to build this comprehensive care management. And for today's conversation, I'm going to focus on columns 1 and 2. The community health piece is important, but it's longer term for most organizations that we work with. Let me dive into the first section here. Elevating. Yes, please.
Michael, sorry to interrupt you. I just wanted to maybe give a reminder to the group, if you wouldn't mind, to place your phones on mute to avoid some background noise. We'd appreciate it. Thank you. Go ahead, Mike.
Thank you. I wasn't sure if I was the only one that could hear that, Tyler. So to shift into the best practice conversation here, again, we'll start with elevating engagement in the episode of care. We'll pull up in just a second here and do our first poll. With episodes of care, these are patients already in the system. They're working with our aligned physicians. But even with patients already in the system, we're often leaving value on the table. We're seeing payers and employers hoping to recover the value by holding us accountable for longer episodes of care. Readmission penalties, a good example of how payers are doing this. And you can see the four key imperatives are, can we activate patients earlier in episodes of care? Can we customize discharge plans and so on? So I'm going to pause just for a second here and ask folks on the line. You should see a poll popping up in your online platform. You can answer more than one, by the way. So it's okay to click all four if you're doing all four. So I'd love to see sort of across the spectrum of folks on the line what you're doing here to elevate engagement in the episode of care. I'm going to wait a couple more minutes here. So I haven't done this poll exactly like this in other conversations I've had around this research, but based on conversations I've had, this looks very much in line with what I've seen before. Certainly, we'll talk about number C there, equipping patients with resources to manage recovery. Can be a fantastic idea, can obviously be resource intensive. So I'll make sure when we go through that section, I'll touch a little bit on how do we think about making sure that we've got the right financial scale in that type of approach. So let me start with the first piece here of the elevating engagement in the episode of care. I think the focus today on readmissions offers a really clear example of some of the disconnects we see between patients and providers. You see here a recent study of heart failure patients found that 70 to 80% of them were sent home with incomplete discharge instructions. This is where the system is failing the patient. We cannot engage a patient if we don't give them the information they need for self-management and recovery. On top of that, we also lose track of patients post-discharge. Bottom of the page, recent study, 20% of cancer patients thought that something, quote, went wrong, close quote, in recovery. But shocking, at least to me, of that group of patients who thought something went wrong, only 1 in 3 informed their provider of the problem. We need partnerships with our patients that extend beyond the acute care episode, especially as you see here when something goes wrong. That breakdown in communication is driving costs in the healthcare system, and it's causing risk for any provider that is in a value-based payment model. And we found that many health systems, they don't quite get it right when they think about what's causing these readmissions. I'll give you one concrete example on the next page. They were nice enough to share with us. This is data research that Kaiser Permanente did on their own. You can see they asked on the left-hand side of the page different players in the health system, what do you think are the major causes of 30-day readmissions? And you see the list on the left there, just in descending order. And then when they actually dug into what was the real cause for the readmission, you can see on the right-hand side of the page, it was sometimes patient noncompliance, but that was 25% of the problem. 75% of the problem was a system issue. And I think probably the most telling disconnect on this page, if you look on the left again, is the number one provider identified, or what they thought was the cause of a 30-day readmission, is noncompliance with lifestyle recommendations. And if you pause for a second to think about that, if you're talking to a diabetic, someone with CHF, COPD, it's pretty hard for any changes they make in their lifestyle to have an effect in the next 30 days. Lifestyle changes tend to be much longer term than that. So again, I think we've got a fairly big disconnect here. So what you'll see on this page is two phases then in rethinking patient engagement in episodes of care. We just, in the poll, saw these already. So first on the left is setting up beforehand a successful episode of care. Can we identify opportunities to engage them early? Can we tailor the discharge plan to meet their needs? Then on the right, post-discharge, how do we reinforce their role in self-management? How do we leverage technology to equip patients in those final steps? How do we create feedback loops so that we do address complications? We don't run the risk of patients having problems and not letting us know. So our first imperative here is activating patients earlier in the episode of care. So ideally, patient engagement starts before they're even admitted. This is an example from iCare Passport. They're a web-based portal powered by Skylight Healthcare Systems. They're doing it to engage patients even pre-admission. Now you see through this work, if you see a little light bulb icon like you do on the bottom of the page, the red icon in the gray box, this is an innovation that we're highlighting. We're not endorsing this necessarily as best practice, but the innovations are helpful to identify pain points, problems in today's system, and where people are at least looking for solutions to improve patient engagement there. So with iCare Passport, providers email patients an invitation to log on. They can access a personalized patient dashboard. It has information about the upcoming procedure, what the recovery plan is likely to look like, educational materials about the condition, pre-admission reminders, paperwork, even a map with directions to here's how to get to our facility. And just one example, Shawnee Mission Medical Center in Kansas, they use this for their bariatric surgery patients because here's a group where you know when the procedure has been scheduled. There are a number of lifestyle and behavioral changes associated with that. And we absolutely need patients to be active members of the care team if they're going to drive the long-term outcomes. So by pulling engagement forward, patients are less anxious going into treatment. They're more prepped for their recovery. I'll give you just a side comment here. I was talking about this work with a health system in North Carolina, in fact, last week. And one of the folks in the room made what I thought was a pretty good comment. She said, you know, I just had to take my dog to the vet for surgery, and they use a system like this. She said, if my vet can do it, then surely we can do it in a health system. And more consumers expect this kind of engagement from us. So our early interactions with patients, they should always reinforce the role of the patient. Other example here, many organizations using patient compacts. They're not legally enforceable, but they identify what providers expect from patients and what patients can expect from providers. This is a pseudonym, but Cosgrove Hospital is a real academic medical center in the West. They actually piloted a follow-up summary and teaching record in one of their medical units. It's a compact that instills this mutual accountability between patients and providers. Patients say, I will agree to comply with the discharge instructions. I will communicate with you. If there's a problem, I promise I will adhere to my medication schedule. So the focus on patient engagement starts at day one of an episode. Our care pathways should reinforce this early engagement. It should help set clear expectations for our patients. That's the first step. Now, beyond these clear expectations, we need to then tailor the recovery plan to the patient. One great idea here is identify patients who will need extra support, and then beforehand design the care plan accordingly. So you see here, Fairview Health Services, they survey each patient, and they do that to determine the patient's level of engagement and then they adjust the care plan accordingly. So for example, if a patient is admitted for complications from diabetes, they have a low level of engagement, the team will schedule more frequent follow-up calls from a nurse. They will prioritize quicker follow-up appointments with the family physician. Those extra steps, not everyone needs them, but the folks who do, it keeps them engaged in the recovery process. And I won't go through it in detail today, but you can see on the next slide here the 13 statements that are included in that patient activation measure. This is developed by the University of Oregon. All statements that will gauge confidence about managing one's health. Based on your answers at the bottom of the page, you are stratified across 4 different levels of engagement. So having this clear picture up front of patient's engagement helps us plan recovery across the entire care continuum. Another example of doing that, this is another student organization, Olson Healthcare, but they do some interesting planning of the post-acute care plan pre-discharge. Now, everyone does discharge planning, but they have a certain set of thresholds. You see them on the left-hand side of the page there. And for patients that hit those thresholds, so they've been here for more than 10 days, or they have complex psychosocial issues, and so on. In that case, you can see there is a multidisciplinary discharge planning team created that includes not just the existing care team, but the post-acute care, the PAC liaison, certainly the patient themselves, and critically for many of these patients, the patient's family. They all collaborate so that together they're involved in deciding what should the post-acute care referral plan look like while the patient is still in the hospital. Certainly, we need to build in expectations about what is the patient's home environment. This is Children's Hospital, Boston. They created what they call a family rounding program where they have the parents, the caregivers, participate in daily rounds. You can see the rounds consist of updates on each patient's condition, reviews of the daily care plan, recovery planning, tailored specifically to that patient's home environment. One member of the team I thought said it well, which is, simple truth is, parents know their children best. Why wouldn't you include them in any in-depth discussion about their child's care? And what we want to guard for here is that tendency for the patient's engagement to immediately go south once they go home. Because as we know, their day-to-day life is very different from the hospital environment. So for many patients, the best bridge we can build from the hospital to the home is one where we continue to reinforce that important information. One example is keeping discharge instructions at the patient's fingertips. Left-hand side of the page, Postwire is an app for this discharge instructions. Providers will record instructions. They're stored on a secure website, which is then available by the patient or a caregiver at any time. And they can add additional content through the recovery process if necessary. So now, if a patient says, I'm not sure I remember exactly what my provider said, they can much more easily access that information again. Another example on the right is Get Well Network. They start with patient education modules in the inpatient setting, but then continue that education at the patient's home. So the patient might take a bedside survey before discharge that tests their knowledge of their medications. Once they're home, that medication information is readily available, and they can answer questions about are they adhering to the medical plan. Care team gets alerted if the modules aren't completed, or if the follow-up questions are answered incorrectly, or if the patient submits a separate question. At Banner Health Children's Medical Center in Arizona, their use of this Get Well at Home reduced their asthma readmissions by 60%. So in addition to reinforcing this type of self-management, we want to look for tools that can make completing follow-up steps easier. There's a recent study of Medicare readmissions. Half of the patients had not completed their follow-up appointment with a provider. So reconnecting patients and providers during the episode of care, that should be part of the seamless process. And improving that process is especially important for our highest risk patients where getting back to the hospital, getting back to the doctor's office, that might not be an easy request. And of course, I know this as a healthcare consultant, no speech about innovation is complete if we don't at least talk once about using a robot in that process. So this example here is Vigo, a robot designed to improve the follow-up process. If you've never seen it, it's about a 4-foot-tall, 18-pound portable robot. It has a video screen, a camera, audio, Wi-Fi capabilities. So the robot is put, in this case, in the patient's home. Physicians then log in, and they can do virtual follow-up. So the provider, without even leaving their house. It's especially effective if the patient's working with a multidisciplinary team. So instead of the patient going to 3 or 4 different physicians' offices, the entire team can be virtually brought to the patient's home. Another example here, we already saw them, at Children's Hospital in Boston, they started using Vigo, not with everyone, but with their high-risk surgery patients. It's a clear case where extra support for the patient and the family, especially in those first few days of recovery, can have a huge impact on outcomes. I want to be clear about one thing here. We are not advocating Vigos for every discharged patient, but when we think about recovery from the patient's perspective, a number of opportunities to reinforce self-management jump out. And keeping information and providers easily accessible to patients, that will impact outcomes on the final steps of the care pathway. Next idea here is, what are the feedback loops? Again, let's avoid that problem of the cancer patient saying, I thought something was wrong, but I didn't bother to tell my provider. Innovation here is from a company called Pipette. They actually create text-based, phone-based, or computer-based mechanisms, programs, where patients can answer questions about their condition and their care plan. It's similar to the follow-up phone calls many of us would do with, say, a CHF or COPD discharge, but it can happen not at the same time. So rather than having to connect live with that patient on the phone, this conversation is happening. The wonky term for it is asynchronous communication. So asynchronous communication is things like email or text, right? So you can have a conversation without connecting live at the same time. Great time-saving tool for both the patient and the provider. And this is another area where more and more of our consumers, our patients, they just expect interaction like this. I have an 11-year-old daughter, and I've learned that for her generation, actually just picking up the phone and calling someone is almost considered rude. It's almost like knocking on someone's door in uninvited. The more appropriate approach is to do a text. That's leaking into healthcare as well. Then finally, we need patients to play a more active role in alerting the system to recovery complications. This is from consultants in oncology and hematology. They're a oncology medical home in Pennsylvania. They developed a phone triage service for their oncology patients who experience any type of treatment-related symptom. You can see they have nurses use then symptom management algorithms to triage those patients. And the results have been astounding. They say 76% of patients are managed at home. Only 0.1% results in a direct hospital admission. You look at the bottom of the page there, over the last 3 years, the team has had phenomenal results. They've reduced ED referrals, and they've reduced admissions, even as the practice has rapidly grown. So I think 2 important parts of the story. One is, as we saw earlier, the team sets the expectation with patients that every symptom counts. They say, if you accept nothing, if you have an issue, call. And then second, they built in support for any patient-generated red flag. So we can't tell patients that every symptom matters, only to have them then call and wait for hours, or in some cases days, for a member of the care team to respond. We have to meet them halfway here. So I'll go to the next page. I won't cover it for today. It's more for later review, but the 4 imperatives from this section. So as you think about this work later, if you want to go and see what the main points were from each section, you'll have that handy. So what we just saw, engagement in episodes of care, that is a critical first step. But now we're looking at, we would argue that good episode management would be the new baseline of health system performance, meaning we have to measure up or we'll get left behind. So as you think about not just in a discrete episode of care, but in driving engagement and ongoing management, our second pole here. So the 4 imperatives you see, how do we identify and prioritize support for the highest risk? How do we leverage data to better identify changes early, and so on? I'll pause for a quick moment here for folks to answer the polling question on this ongoing engagement. Interesting. So far, a bit more of a skew than our first one. And again, this is another one I'll keep in mind here as I go through the next set of imperatives. So with those in mind, here's a way to think about it that puts it, I think, in a little bit of context. These are the same four imperatives we see in the poll for building the infrastructure for engaging in ongoing management. But we're now looking at sort of a split of how much of this is active on our part, how much of this is passive on our part. So on the left, with the highest risk groups, we have to identify those patients. We have to deploy the right care team to support ongoing management. Next, though, is a little bit less intense, and now we have targeted care managers. So with this group, we're going to use innovation to alert the team to any unexpected change in health status. If necessary, re-engage individuals with whom we've lost contact. This is the place where we'll also open smart access points and encourage patients to reach out to the health system before any low acuity symptom escalates and gets worse. And then finally, in some cases, automated self-management. This is across the entire population. How do we leverage technology to encourage healthy behaviors even when we are not actively involved? So we'll start with the left-hand side there, number 5, with the intensive case management for the highest risk populations. As we take on contracts for population management, our biggest short-term wins will come from dramatically changing the utilization pattern of those patients. And today, typically, this group falls through every crack in the fragmented system, and they often end up in the ED, even readmitted to the hospital for preventable care needs. So our first step is identifying which patients need that intensive management. This is from Adventist Health in Portland. They use an internally developed disease registry to find these highest risk patients, at which point case managers then reach out and develop a customized care plan. So not done for everybody, but just for the highest risk. But one thing we liked here is they don't just look for the top 5%. They actually also leverage the disease registry to predict soon-to-be high-risk patients, those with, for example, a number of missed care needs. And they will then proactively manage those patients to prevent them from escalating into the highest risk category. There's an example from Commonwealth Health Alliance on the next page, how they try to address the complete continuum. They do this with dual eligible patients. So you see, for those patients, the ones that are deemed highest risk, they get referred from the primary care physician to a care team on the left there, headed by that NP. So you can see what the NP does. They are the head of it here, but they have the access to physical therapists, palliative care, and critically these days, behavioral health. I won't go into the details today. I'm going to assume many folks on the phone are already aware of this, but many of the causes for readmission are not clinical in terms of the condition per se, but they are behavioral health issues. Good luck getting someone to manage their diabetes if we haven't addressed their depression or other cognitive issues there. So more and more today we see a focus on behavioral health. If we can't fix those problems first, we'll never get the patient engaged as we would like. We also see consistent check-ins between the team and the patient. They're helpful to establish just that expectation of ongoing management. This is from Duke University Medical Center. They have a program called CHANGE. It's an acronym for cholesterol, hypertension, glucose education, where primary care physicians select their highest risk patients, and they have them participate in monthly follow-up calls with nurses over a one-year period. So nurses will then focus on a range of topics. They'll cover basic disease management to motivating behavior change. And one of the especially promising early results was they found patients became more active in those calls as they went on. So patients would start preparing questions for the nurse to make the session more valuable for both the nurse and the patient. So the approach here is to high-risk patients. But I want to stress, even with something like this, only a high-performing system can prioritize these calls. Too frequently, we hear these programs get sabotaged by the tyranny of the urgent. So in our intensive care management system, management calls are equally important to in-office visits to maintain that patient engagement. We also would argue we need to do a better job in just understanding the real day-to-day lives of our highest risk patients. Today, the primary care team is often forced to manage blindly. So when they come in for a visit, the patient is asked, and they then underestimate the severity or the frequency of their symptoms. And the result of that is the physician can overestimate the success of individual management. This is especially true with conditions like asthma. Patients chronically underestimate the frequency of acute attacks that require their inhaler. And unless they end up in the ED, the care team cannot accurately calibrate the plan. So in this example, Asthmopolis, they use a real-time link for patient management. GPS sensor is attached to the patient's rescue inhaler, and when the rescue inhaler is used, a notice is generated, including the time and location of the attack. Patients then get a text message and weekly summaries with tracking information. So the provider, they know of any abnormal spike in utilization, and they can access the trend data, lets the care team change the care plan if necessary. So responding to either symptoms or side effects that aren't well managed, it's important. We don't want patients to accept poor outcomes as normal. And ultimately, these changes can help improve the quality and overall cost of care. So when prioritizing care management support for our highest risk patients, it is straightforward. Identifying the role with lower risk patients, that's more challenging because by definition, the group is well managed today, the diabetic that's adhering to the care plan. But we want to know as soon as possible if one of these patients starts to have a problem. So if their HbA1c starts to trend upwards, we want to activate the care management team. We want to offer additional support to re-engage that patient. So you see here two imperatives for building the infrastructure for that more targeted care management. First is leveraging technology to alert the care team to patients in need of support. Second, can we open smart access points to promote patient engagement at the more low acuity sites of care? Now, I know this is a high-tech example, but an interesting one here in the monitoring. This experiment from the University of Missouri, Sinclair School. They have actually, with some of their patients where they need to do this, have put Xbox Connect, carpet fiber sensors, they track motion patterns, they track activity frequency. They then will monitor the data, those sensors. They get transferred to the electronic medical record, and caregivers get alerted. So if someone who is typically fairly active is suddenly not moving around much, they're alerted. They can contact them. They can offer reinsurance. We can give medication, medical attention if it is warranted. Now, again, think about this. We can't do this for every patient. It'd be nice possibly if we could. We've always got to focus this on the more intensive needs. But we're also seeing innovators tap into data generated by, say, smartphones to monitor the level. So we can't put the Xbox Connect sensors in everyone's home. Many more patients have a smartphone. This is Ginger.io. They gather data from mobile phone sensors, and they translate that information into indicators of health. You can see the title of the page here. This is what Ginger.io told us. They said it essentially generates this check engine light to identify the 30 patients that we need to check up on today. Give you an example of what they do here. Think of the possibilities. So your cell phone has GPS tracking. They can track you from home to work, work to home, other locations. So if you stay home sick on a work day, that's an obvious change in the tracking data, and it presents itself. And you can have similar patterns around calling or texting. Again, any potential drop-off in activity could suggest the need for attention. Now, just to be clear about this, the individual data points here are anonymous. So it's not recording where you are, just how often you change location. But they're already working on this. They're partnering with providers and patients to feed the data into local health information exchanges, making this wealth of information available to every provider working with that patient. So with the more well-managed patients, we can take a more hands-off approach, but tools like Ginger.io can be incredibly powerful in finding the small subset of those patients who are experiencing a minor decline, and we need to intervene. So, again, a summary page. Population management requires a much more responsive care management engine. And given that we have limited resources to accomplish that task, we need to always leverage technology to prioritize our care team's attention and, again, encourage patient self-management. So again, here are 4 imperatives for ongoing management. I'll take just a couple of minutes here and start to bring us to a close. So again, we saw this page earlier. Now we have the phases of value creation with our imperatives mapped to it. The only comment I'll make here is this is in order for a reason, meaning the left-hand side of the page, what that gray shading implies is this is where we're already losing value in the chain. This is where we need to stop the bleeding, if you will. And then as we move forward, that's where we think we can start to create more value. And we will certainly see rapid innovation across the next few years. And we think there are 2 ways, the left and right side of this page, where our industry might transform to meet the demands of this value-driven market. So it could be, on the left, that the disruptive innovators take the lead here. What will happen is that will fragment the delivery system further. We'll ask patients to take on their own role as care coordinator. Last time we checked, there were 17,000 health apps here. I think they're great target solutions to some problems here. But on the left, the whole is no greater than the sum of the parts. What we hope happens on the right is that health systems lead the transformation, that we leverage innovation to build a more cohesive system. We partner with our patients to offer this more comprehensive suite of services. So innovation is still a critical part, but it's innovation within a coordinated approach, looking for synergies to drive quality and cost improvements. And ultimately, our hope is that this transition to value-driven market means we can take, finally, patient-centeredness seriously. There has been a lot of lip service paid to a patient-centered approach for a long time. We've always looked to do what's right for our patient. We know that, even when the economic model wasn't necessarily aligned. But the good news here is that we are finally approaching a moment where what we're doing clinically for our patients and the economic incentives are actually aligned around being patient-centered. And that gives us great hope that we can actually start to make better progress here. So I wanted to make sure that we